This week on the BackTable Podcast.
If you change the system such that it performs optimally for the folks who are most at the margins, literally you're then creating a system that is like top notch, right? That is going to work really nicely for everyone. But it's the threats to power, right? Folks don't like things to change because it's that assumption that if it changes for this group or if this group gets more, I'm going to get less. And the reality is that that's just not what actually happens.
Hello, everyone, and welcome to the BackTable OBGYN Podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com.
Hello, welcome back to another episode of BackTable OBGYN. I'm here with my co-host, Mark Hoffman. Hey, Mark, how are you?
Good, Amy. How are you?
Good, thanks. And then we are so honored to welcome to our show Dr. Teni Brown. Dr. Teni Brown is board certified in OBGYN and an assistant professor of OBGYN at Northwestern University Feinberg School of Medicine. She completed both her residency and fellowship in urogynecology at Northwestern. She is at the forefront of multiple diversity, equity, and inclusion efforts across Northwestern medicine. She's the first director of Diversity, Equity, and Inclusion for the Department of Obstetrics and Gynecology, and is also the Director for Diversity and Inclusion for McGall Medical Center. So welcome to the podcast. I have known Teni since she was a fellow, actually.
Yes.
So it is so nice to see you continue your work, what you did in residency and fellowship. And I think it's always instructive for our listeners just to hear about your journey, how you got interested in this, and how you built your portfolio.
Yeah. Oh my gosh. Yes, it's so crazy, Amy. We have known each other since I was a fellow. Oh my gosh. So where do I start in terms of background? So I'm an immigrant. I grew up in Nigeria and migrated here when I was 12 to the United States. And my journey to medicine wasn't always straightforward. I was actually a middle school teacher for about 3 years after undergrad, and then went to medical school, and then came to Northwestern and stayed here. But specifically how I got interested in urogyn is because it's just the best subspecialty, like, come on. But the patients are incredible, and it was so, life-changing and cool to be able to take care of people and take care of quality of life issues. I think that really resonated with me. And if you haven't realized, a huge part of my scholarship, my leadership and advocacy is around equity. And I think it's just a field that is so ripe in terms of opportunity to really advocate for patients, to really elevate voices that may be marginalized. So it just was the perfect fit, both professionally and also from a perspective of the things I do outside of work.
Cool. What are the kind of things you do outside of work? Because I think people are always interested in that.
Yeah, I love community advocacy. I think that was actually probably one of the things that led me to be a teacher before going into medicine. The idea of pouring into communities where you live, that are adjacent to where you do day-to-day life. And so I love getting out into the Chicago community, meeting folks that look like me, and connecting with them, just not as a physician, but like a fellow Black woman. I do a lot of equity-focused research. That is my jam. And specifically, my research focuses on older Black women with pelvic floor disorders. And then I like interior design.
Oh, wow.
That was for if you were listening. Well, yes, I do. That's like the other thing that I like to do on the side, but
that's awesome. I no wonder. I always say urogynecology is vagin architecture.
It is. Isn't it?
It's a vaginal place.
It's rehab.
It's vagin architecture. We're vagin architects. So anyway, I appreciate that you are trying to make things nice and pretty in a house, because that's what we're doing
with our work.
The vagina.
Yeah. Yep.
Yeah. So, you have to have the eye for that and the feel and reconstruct and, have vision.
Yeah. And make spaces that make people feel good. Is that not urogyn? Isn't that urogyn? Seriously.
I know. what I'm saying. I love that. I love that is part of it, because there's definitely like a 3D component and just having some vision of what could be in this space. So I do appreciate that. I hear Mark's silence. That's Mark's like,
we went to the vaginas too quickly, right, Mark?
Look, I'm a gynecologist. I'm not afraid to talk about vaginas, but I think there is, in my years and in doing this show, learning when to shut up is sort of a skill I'm constantly working on. And you guys had a thing going, and I was enjoying it and not trying to, just say something to say something. So that's something I think that you guys were doing just fine without me.
That's fantastic. I do think that equity piece is so important. Tell me what you think equity means in the context of urogynecology or OBGYN.
Oh, it's a good question. It's a loaded question. So, I think you can think about it in different ways, right? So if we start in as it pertains to our workforce, right? It's like who is represented, who's showing up, who is in academic spaces, right? Or in leadership. And so, part of my work is workforce development and making sure that our workforce is reflective of the population we serve. And OBGYN is really good at that compared to other surgical specialties, actually. But equity isn't just representation. We have lots of women in OBGYN, but then when we start, delving deep into what kind of positions and opportunities are women occupying in those spaces, that's when you start thinking with an equity lens. And it is not necessarily, it is disparate in terms of if you think of the top leadership structures and who occupies those, mostly men, right? So that's one potential piece in terms of what equity can look like, is that are the opportunities that are available within the specialty actually equally accessible or equitably accessible to different populations, right? Whether that's by race, class, gender, et cetera. And then we should always be thinking about it as it pertains to patient care, like our outcomes, right? Does everybody get to benefit from the advances that we have? In urogyn, for example, what we do is make people feel good, make their lives better, right? And one way that I think about equity in urogyn is, well, who's actually benefiting from all these awesome things that we have? Amy, we were just on the phone the other day talking about how much we love Botox, right? And then what equity means is is everyone able to get that? Is everyone offered that? Are there certain people that are kind of left out of the pie? I think it's when. Then who's also represented in our research, for example, in urogyn research, which is, we're not an anomaly, let's be clear. But the research is very white. And we know that all women have pelvic floor disorders. And so, equity for me, or thinking about equity in urogyn spaces specifically, is also thinking about what voices are loudest and most represented, and thinking about how to bring some balance to that.
Absolutely. I think the access is so insurance mandated, and what clinics you get to go to, what kind of resources you're allocated, and then what meds are covered. I actually think Medicare is a real equalizer, in that regard, because I know for Medicaid, what we can prescribe, for instance, for OAB or overactive bladder meds, it's really different based on their insurance. I know you did some advocacy on that front in the state of Illinois, right? Can you tell us about it?
Yeah. So in Illinois, what we did for the past year, myself and actually a midwife and one of our general OBGYNs, we're really lobbying to have the Illinois Medicaid preferred drug list changed in terms as it pertains to OAB meds. So the only medications that were on the preferred drug list were anticholinergics. And anyone who is an OBGYN or definitely a urogynecologist, urologist, knows about the data around anticholinergics versus beta-3 agonists in terms of the side effect profile and risk for cognitive side effects. And so I think with a real systemic lens, right? You talked about insurance, but insurance there are some systemic policies that determines who gets what insurance and who doesn't, who's employed, right? And who's not, who has access. Even though Medicaid care is an equalizer, you have to be 65 to get that. So, but what happens in your life before 65, where you're on Medicaid before that? And I think those systems that are in place that put you in a position to get a certain type of insurance don't magically go away when you're 65. So what we did was lobby for Illinois to include beta-3s on the preferred drug list without prior authorization, and it got approved. So it's going to be a game changer, right? Most of the individuals in Illinois who are covered by Medicaid are Black or Hispanic, right? Obviously, individuals who are lower income. And now they will be once this passes, they'll be able to get access to our 2 drugs that we feel are the premier in OAB medications without all those hoops that people have to jump through. And my hope is that it changes prescribing patterns. And so that's what we did. We just sat on them and made the case for like, this is an equity issue. And this is a structural issue where some of the work that we'd done before that was published in JAMA showed that Black individuals were the least likely to receive a beta-3 agonist. And immediately people said that's probably insurance driven. Well, let's change that. And so that's what we're doing in Illinois.
That's amazing. How did you lobby for that just as a roadmap for other people who want to take this route?
Yes. So in every state, there is a department that manages the preferred drug list, right, for Medicaid. Medicare is a different beast. And all it is physicians just writing to somebody or asking, can I come to your next meeting or your board meeting where the decisions about what drugs are on here are determined? When I went to that meeting, Amy, what's shocking is the drug reps are there, right? They're like no physicians there. Physicians don't show up to these things. And we have such a unique lens, right? We're the boots on the ground and we know what the patients need. First of all, the patients tell us what they need. And it's just a matter of reaching out to them, making a case. It was a 1-page document that we created outlining what we felt was the problem, what some potential solutions could be. And then there was a hearing, took 30 minutes, and then they voted on it. And that was it.
Are you kidding me? What?
I mean, it took almost a year, but it was just like, okay, we'll come to the next meeting.
It's amazing what you can get done by just showing up. I mean, it's your
Absolutely.
time. It's valuable time. It is work, no doubt. But as Amy's asking the question, I'm thinking the same thing. Well, how do you even do that? I mean, there's, we just assume, like we assume for so much of the world or the government or healthcare as we're dealing with it, it's just, it's baked in. And we know this. We know things are built and designed for the outcome they produce, and it's not always great. And so to change that system can be extremely difficult. It can be extremely challenging. And so finding ways to actually make a difference for a population that size is incredible. I mean, it really is. And I hope others that hear this go, oh, maybe I can do that. That's something that maybe
we hope
I should
people
do that
will.
in my state. Yeah.
Yes.
Yeah.
Yes.
It's a wonderful story.
We're going to write it up. We want a snowball effect, right? That folks will replicate that, and then there'll be better coverage, hopefully, in many states. Because very few states right now actually have beta-3 agonists on the Medicaid preferred drug list. It's got to be without prior auth. You want to push for that. They'll try to tell you maybe, no. We want without prior auth.
That's awesome. So is it both mirabegron and vibegron? Wow, that's amazing. Well, what an example of just addressing it at its root, the coverage issue. I remember in residency, like we were talking about the progestin IUDs, and like even private insurance was very difficult. I'm dating myself now. Mark and I we couldn't give our clinic patients, we couldn't insert the progestin IUDs. And then it was mandated coverage, and there was just more private insurers. They did the cost analysis, and they showed it's cheaper to cover a $500 or $700 advice than to get pregnant once, which it just seems like a
surgery if it's going to keep you out of the OR. I mean, it's like a lot of times they just don't know. And I've got some colleagues in my time working on that Committee for Health Economics and Coding, and they're like, we actually want to do the right thing. Insurance companies actually want doctors to do the right thing. And most of the time, whether it's insurance or whether it's a state, most of the time, these guardrails are set up because people are overprescribing things that we don't need, or they're trying to sort of decrease cost. And look, they're a business. I'm not trying to defend any corporation, but the business is important for many people to get health care, and they're trying to make it one that is sustainable. And so sometimes they do want education, and the folks that I've known that have worked there said, no, like you just need to explain it to us in a way that allows us to, like, there are people within those organizations that actually want to do the right thing and actually want to make it right. And oftentimes it'll save them money. I mean, it's just they don't know. They're not the expert like you guys are.
That's so huge. Like there are folks who want to do the right thing, and we can just show up, right?
Not everybody who works at an insurance company is like twisting their mustache, like looking for ways to like let people die. Like they're people. They work at a company. They have a job, but like most people want to help, and sometimes just finding ways to let them help is most people want to help out. I believe that.
Yeah, I think that insurance is a huge, and the work status is a huge issue. But like, what other kind of systemic barriers or social determinants of health impact our patients?
Yeah. So I
remember we only have an hour for the show.
right. But I love to talk about this. So this is not exhaustive, but like there are disparities, and where you live, like your built environment, your neighborhood environment is a social determinant of health. So let's take Chicago, for example, right? Chicago.
That's where I did my residency, University of Chicago.
So you know this, Mark, where University of Chicago is located, very different health outcomes than the Gold Coast, where Northwestern is on the Mag Mile, or take it even further south or far west side, right? Like if you start going to the far west side, people used to talk about around University of Chicago, that's Hyde Park. Their outcomes are actually equitable for some folks, right? But the far south side is really, really segregated. And the reason why neighborhood and built environment is a social determinant of health is because to the point that we made at the beginning is it determines allocation of resources, what you have access to, and it is structurally and historically determined. So in Chicago,
redlining is
thank you.
It's the number of people who just never heard of this or don't know that, like,
it's crazy.
It's not like, oh, they did this thing like quietly. Like it was in the law. Like it was not. It was law. It was law, right? Like we talk about like good trouble and those kinds of things. These were the rules. You had to break the rules to do the right thing, to do the just thing. And those things are built in concrete and stone and metal, and those buildings and the highways. Like to undo that work is monumental and monumentally expensive. And so we have to work harder to overcome those built-in, baked-in problems. I mean, I live in Kentucky now, where I grew up in a college city, but Eastern Kentucky, I mean, again, a different problem, right? Talk about equity. These folks, Chicago people didn't like the hospital that was near them. Mm-hmm. There are no hospitals in some of these places. It is hours from any care, and the care they're getting, it's not consistent with what you see in a big city at any hospital, let alone it can look all sorts of ways, but these things are built to look a certain way, but it's built to be a certain way, and it's a lot to overcome. I mean, it's big. So yeah, no, I've seen it for sure.
I love the word that you said, baked in, because that's, I mean, we have to think about it that way, right? So can you imagine trying to change the outcomes, the health outcomes for population, and you're not dealing with the things that are baked in? It's like you're just like, you're making some maybe small incremental advances, but you really have to change the underlying structures. And so I'm a fan of this term multi-level. Like any intervention, the best interventions to combat inequities are multi-level interventions. You got to do things that, yes, are at the patient level, but you can't forget the baked-in things, right? The stuff at the provider level, the stuff that's, like you said, baked into the environment. And those things are hard. I think those are the hardest to come up with solutions for.
Yeah, I mean, Amy knows this, but I'm a chief medical officer now, so we're looking at not just our university, not just our hospital, but the state, and how we overcome challenges of access to care across a huge area with just such different challenges. But looking at, I mean, urban problems are unique and different, but also even though the mileage is less and the proximity is similar in distance, but I can hop in a car. Other people have to hop in a train. I got in a car accident. I lived in East Lakeview, and I got in a car accident and had to take the bus one morning to work. Had to take public transportation from East Lakeview to Hyde Park. And it took me an hour and a half, and it was trains to buses. And you go, I mean, this is what people do every day, right? This is not, a funny story to tell. This is like this is people's every day to get anything done. Everything is harder. Everything is harder based on where you live, where the grocery stores, hospitals, the necessary things. Like, it's just harder for almost everybody else than me. I mean, realistically.
That is such a good point. And then access to the transportation, literally which clinics you're going to, it's for sure systemic barriers. And then can you just give like a thumbnail sketch of redlining? What is it?
In a very sort of like quick way. So redlining was this practice, and it was sanctioned in law, right? So the historic housing policies for assigning or like approving loans for individuals. And it was this practice where portions of the city were basically color coded based on the perception or that the individuals applying for those loans were how likely they were to default on the loans. And so in certain areas of large urban cities, people would get together, like those who were in power, to say, okay, the folks who live in these areas are going to be most likely to default on their loans. And so we're going to mark these areas in red, and we're going to reject them when they apply for a loan, whether it's a business loan or a homeowner's loan. And areas where they felt like the individuals would be able to pay and that they would be less likely to default on loans, those areas were marked in green. And so they had these maps basically of urban areas, and they called them redline because there would be these red lines around these areas that were considered like no approval zones, essentially. Interestingly, those areas ended up being the areas where mostly Black and Hispanic folks lived in almost every city where this was done. It was racist. This was a racist practice. It was sanctioned under Jim Crow laws. There's more detail. But what came from that is, when we talk about patterns of how folks are spatially distributed in cities, that is the historical underpinning of how you can go to a city and someone will tell you that this neighborhood is a Puerto Rican neighborhood. This is a Black neighborhood. This is historically a white neighborhood. That's not just like, oh, folks got together and decided they just wanted to hang out there. You are more likely to be sort of like concentrated in these areas depending on what resources that you had and like how likely you were going to be allowed to settle somewhere else. And what was also tied to those patterns was then the sort of subsequent investment in those areas. So the areas that were redlined were less likely to have prominent, like business investment. So small businesses were not going to go to those neighborhoods. The education resources also deteriorated in those areas. And all these trickle-down effects, like to your point, there are less grocery stores there. There's no Starbucks in those neighborhoods, right? I feel like we have this little joke. If the Starbucks comes, the neighborhood is getting
gentrified, yeah.
It's getting nice, right? Or quote unquote nice.
Well, and the generational impact, though. So if you're a family and post World War II, you fight in the same war as the guy next to you, looks a little different. You come home, they get a home loan. You can't get a home loan. Why? Because of the color of your skin. Well, I can't buy the house. Well, look, there's these high-rise apartments that are low rent that you can rent that is owned by somebody else, that now you're not investing in your house, right? Mortgages, the idea that a mortgage payment is the interest off your mortgage is tax deductible, but not in the rent, right? So we're making these tax loopholes for people who get the loans, and the other folks who don't get the loans, who are forced to rent, never get to build that generational wealth. They don't get to buy that house at $50,000 in 1951, and then later on it's worth $1 million because the city grew up around them. Like that opportunity never happens for huge chunks of cities, and the generational impact, the kids and their grandkids, because they were never allowed to buy a home when interest rates were low or when homes were cheap, or we had all these post-World War II incentives. I lived in a post-war area in Ann Arbor, all these little cinder block ranches, affordable. You could get the same jobs, but you couldn't even buy the house, even if you had the same money. So the generational impact is the other piece of that too, that you just keep knocking folks further and further and further back, and then go, why aren't you keeping up with me? It's like, well, because you've changed the rules. You've made it more difficult. So we could go all day about just redlining in general. But yeah, basically just systematic, baked in, that made it much, much harder for people of color to have any semblance of success compared to those who look different than them. And that was the law. It was totally legal.
Yeah.
Which is crazy.
Well, tell me, like, what can you talked about this as like a lot of what, I mean, it's your life's work in terms of your, what you like to do outside work, what you like to do at work. It obviously fills your cup. We can rail against the injustices, but like, what are you doing to address these things? You obviously did, you went to the Medicaid, you're focusing on your scholarship, you're doing some outreach. Can you tell us a little bit more about these efforts in these realms? And then you're working in your institution, both on your department level and on a medical center level. So tell me like what your thoughts are on how you incorporated all this.
Yeah. So I think the big thing is I have chosen to have an assets-based mindset when thinking about these issues, right? Like you said, it's very depressing to just like harp on the things that are the problem. And I do believe in being action-oriented. So I'll just give some examples because I think this is, I like to hear people talk about the work that they're doing because I think that you should be, I'm automatically thinking about how can I make this apply, how can I apply this to my realm? And we should all be learning from each other. For example, one of the first things that I started the podcast with was saying, workforce, the composition of the workforce, right? And so at the institution, my GME role, that's something that we think about as help programs, think about who they're recruiting and who they're bringing. But honestly, it is not enough to just bring people there. My job in that role is to make sure that the folks that they bring in actually thrive, because I think it's so harmful to bring a bunch of people to an institution that does not support them or is not set up to support them, both in the terms of who's receiving them, like the environments they're going to be, what the learning environment is like. And so we have put in some concrete things in place. Like, for example, if there's an individual from any protected class, this is not just race-based, that is going to face some sort of disciplinary action, there is a rigorous multi-level review process with an equity lens throughout to ensure that this is not just something that is happening because this individual is just hyper-visible, and has this individual been given all the opportunities, right, that other people may have had to whether it's course correct or is there even an issue here? So making changes to disciplinary processes, because we have GME data that when you look at attrition from GME programs, it's highest for individuals who are Black. You can look at that from the AAMC data. And so that's one thing that we've done. In our department, some of the work that I'm proudest of is what we've done in the Department of OBGYN. We embarked on a journey a couple of years ago. And I say a couple of years ago because this work is like long and slow. But we basically started out by just saying, okay, where do we stand in terms of how folks in the department feel about their experience, particularly folks who are marginalized? And we used that data. We did a huge survey, alumni from 10 years ago, the faculty, the trainees. And then we used that and we assembled a committee, not a DEI committee, just like a committee of some key folks to say, let's look at this data and set out a strategic plan over the next 5 years. So there are things from programming efforts, community engagement efforts, changes to recruitment processes in the programs, both at the residency level, at the fellow level. And that's basically like our bundle, our equity bundle of things that we do to actually move the needle and actually achieve these goals that we set for ourselves. For example, one program we started health equity rounds to review some cases that have very prominent inequity features and social determinant of health issues. And it's not like a regular M&M. The whole goal of that conference is to come up with 1 to 3 action items that are at the system level and change something. So we've had 4 of those. And from each of those activities, there have been system level changes. Like, for example, one case in particular led to a change for the NM-wide security policy and security policy as it pertains to law enforcement participation in patient care or adjacent to patient care. And that came out of our conference. And we track these things in terms of what the case is, what the action items are, and what change happened in terms of process changes in the department as well as institutional changes. So that's some example. I could keep talking, but that would be boring.
Yeah, no, I remember, as you're talking about the security, I remember in my previous job, a patient left AMA from the emergency room and he died in a altercation with the security forces. And like, I remember our colleagues and I were like, just let him go. Like, what? I mean, I think this person was having like a mental health episode, but it was like, you don't need to restrain this person that, I don't know, whatever happened, it sounded really bad. And these are Mark's kind of headaches at your level now, you know? You're like, yeah.
No, I mean, I get an email, not about, hopefully a fatality, but yeah, we get emails every day about, you can't imagine the emails I get. But yes, things like this is part of my day for sure.
Your portfolio of dumpster fires of your
or the patient complaint that the hamburger came without the meat. You're going, like, how do I filter some of these messages out? That was an actual incident report that I got.
That is weird though, not to get the meat in your hamburger.
What was weirder?
That's
what was
just
weirder
rude.
is one of the other CMOs said they got a similar complaint of a chicken nugget without the chicken inside. Like how does it even get out of there?
About that. That's crazy. What is
like
it
it's just like the shell, just the shell of fried. Well, okay, so
Mark,
back to other
this job.
There's no one that has more fun than we do. No, I think about all the things you're doing. I think about the work you're doing with the city, but also the university. But as we know, there have been some states that have recently passed some laws that have made this work a little more challenging, as if things aren't hard enough. Let's just make it a little tougher. Speaking of things being baked in, can you tell us a little bit about that? Like what's been going on around the country the last few years?
You mean
specifically? That's a big question. Specifically related to DEI initiatives and things like that. And
you mean the weaponization of just that, even the term DEI?
Wokeness.
Yeah, and so
the woke mob.
I hope that people catalog this and this gets into textbooks because it's like so wild. First of all, the concept, I would say most people don't even understand what the D and the E and the I are in DEI. And honestly, anything that pertains to, for sure, folks of color, people just kind of lump into DEI. People will say, you do DEI research. I'm like, no, I do health equity research. There's a difference, right? So that's the number one problem. It's just work that people are trying to do to advance. And I mean, this is work that we should all be aligned with, right? Making sure that everyone gets to benefit. It's actually good for everyone. If you change the system such that it performs optimally for the folks who are most at the margins, literally, you're then creating a system that is top notch, right? That is going to work really nicely for everyone. But it's the threats to power, right? Folks don't like things to change because it's that assumption that if it changes for this group or if this group gets more, I'm going to get less. And the reality is that that's just not what actually happens. And so
we see it in the public
scary.
schools. And people think, oh, if my school is not as good. It happened a lot during COVID. A lot of people we know left to go to private school. It just couldn't do it. It wasn't great. But what you find is that when folks that have means go to a public school that needs help, those people have more time, energy, and money to invest in the school. And all of a sudden the school gets better for my kids, but also everybody else's kids. And so the whole, the community benefits when we have community investment. Like my wife worked in Chicago for the Metropolitan Planning Council, lobbying to make parking more expensive. Well, that's not good, except that it means more people take public transport, which means it's better because more people with power complain that, well, the subways, their buses weren't nice enough. So there's more investment. All of a sudden, all those folks that had to take buses now get better buses and trains because more and more people are taking it. And so I've seen it in public transportation and public education and, why Chicago, you can't build east of the river, right? At this point, right? It's we all benefit, we all share. It's a better city for everyone. There's free stuff living in New York City, free shows, music. It's great for people that have means, and it's great for people that don't. Everybody gets to enjoy these things. It's one of those things that just drives me crazy when people convince themselves, well, I have to just do it my own way. It's but if you stayed, and everybody stayed, and we all put and invested in these things. And the same is true with healthcare too. I mean, it is something that we've sort of witnessed in a way just with our kids in public schools, and to see how by us working and being involved in other families investing, how the whole school benefits. I mean, it really is. It's not that complicated. It's not that hard to do.
It's not that hard.
But you have to not be scared of people that are different than you, and diversity includes people like me too, right? You got to all be together, and there's a lot we can learn from each other.
I don't think people realize that equity or diversity includes people who are what you alluded to in terms of the rural folks, people who are coming from a different part of the city. It's not just race. It's like socioeconomic status. There's a lot of different things. In terms of equity, I think it has to do with staffing. Do you want all your clinics to be staffed like equally well? Yeah. I mean, this
Can we
one
talk
clinic,
about resident clinics? Is this the right place for that?
Yeah. Well, that got,
Maybe
I remember
not.
that resident clinic got revamped.
There's so much your residency, which one?
Oh, in Pittsburgh. Because we had our own resident clinic, but now it's all incorporated. They're all like the faculty.
UNC did that.
Oh, really?
Mm-hmm.
Yeah.
They published
so there's
on
no
it.
private. Yeah, there's no private practice anymore. It's all
I'm
like,
very interested in learning more about that one of these days. I won't get too into it.
I mean, it's people feel very strongly about it.
I'm fascinated by this. It's one of those things you said as I've gone along. I'm going. It just seems like we have like the real clinic, and then we have like the the
Mark,
free dental clinic.
Say it.
Listen, we can study the outcomes. We can study what the patient population demographics are. It just isn't the same.
Talk about baked in stuff, right?
Baked in stuff, and this is GME section, right? All of it, and I think the intention is good. It doesn't have to be coming from ill intent or evil, but you can try something. Actually, you know what? I think that was I said something that I thought was going to be nice, and it turns out to be offensive. Like it happens all the time. Own it, learn about it, move on. And I think some of these things that we built, we baked in, that maybe we should look at these things again. I think there's opportunities
and re-examine what you said, Mark. That's actually an equity lens, right? Like, and it may not turn out that what you ultimately decide is, it may not look the way that one institution did it, but you have to challenge the structure and question why it exists the way that it does. And then anytime someone says, well, this is the way it is, I always say that you have to stop, right? And say, well, let's go back to like when it was created, like why? Like what were the issues there and what's different now? And then the other part is to not be performative when people try to address some of these structures like residency clinics, right? I think the wrong way is to say, okay, because I'm getting some heat, let's close them all down and have zero plan for managing that. And because the reality is like it can still be inequitable when you merge it, right? Like,
or equity theater where you have the person come. We have Dr. Teni Brown coming to our university, give grand rounds, and then we keep doing the same stuff we've always done, right? Like that's the other part of this. Like talking about it is helpful, and this is good conversation. But the key is to then for me to turn around and go home and try to evaluate opportunities. And again, now at my executive level, I mean, we think about this stuff all the time. And we got to have representation at our level to make sure people are reminding people that look like me, you got to look at this other thing too that maybe you weren't thinking about, and being open to saying, that's a great idea. I hadn't thought of it, and thank you, and leaving the door open as opposed to, oh, what do you mean? You're saying I'm a bad person? No. Like being open to saying let me think about that. Let me look at that in a different way. I can't put myself in other people's shoes. That's a naive thing to say, but I can at least listen. I can at least try to understand what you're trying to say and where the potential issues are. That's what I get to do now as a CMO. It's a really fun part. Is part of what I think annoyed so many people about me was that I was always like, we can do better. Why are we doing it this way? It drove people crazy. But now I get to do that for a living, and it is a lot more fun. And we actually get to take that question and then work on solving problems. And so, yeah, it is. When I was like cringing when you were saying, well, this is how it's always been done. It's one of those things that makes my blood boil. It's like, yeah, but somebody decided 50 years ago we're doing it, so now that's just how we're going to do it. Like, that's not a reason.
People love it to be a reason, though.
But it's the worst reason.
It is.
It's the worst
lazy.
reason.
It's lazy.
It's so lazy.
It's so lazy.
It's just like, I don't want to change what I'm doing. It's just extra work. Like, okay, but what we're doing is not as good as it could be, so why don't we make it better? But no, I get it. People are burned out. People don't want to do that stuff. But, having people like you and having folks that are in positions of leadership and positions of influence to be able to say, this is important and I'm going to do the work and I want to make it better for everyone. Going back to what you said before is I'm going to change the system to allow everybody to benefit.
One of the questions I was going to ask is like, how can hospitals, how can institutions like medical schools, departments foster a culture of equity in their practice. But I think it's just made up of people and like that fostering that sense of curiosity and like doing better. It is such a keystone of that, because it's about an attitude. It's
and
about
disrupting.
And disruption. It's like a mindset. It's a shift in mindset. It's like constant innovation and desire to do better. Is, I think, culture of equity is not as descriptive as like just trying to innovate and do better. It's like, it's another way of saying it, right?
To the point, I do love what you said. It's like people trying to make it seem like it's this thing that only certain people can do or whatever. But Mark, in your role as CMO, if the leader can set things up in such a way that it is disruptive, that's huge.
Yeah, no, I think that creating that culture, because culture is top down. Like if your culture above you is not what you want, good luck. I mean, what was the quote I heard? Be prepared to die on the mountain, trying to change culture up. But now that I'm lucky enough to sit in the seat I'm in, and my partners and my boss, I think we all see things in a much more similar way, and that we just want the right answer. I don't care who comes up with it. I don't care. There's no ego. There's no like, this is my thing. It's like we just want better. The things keeping us from being better, the things keeping us from excellence, is typically less than we think it is. And most of the time it's people wanting to hold on to what they've got. We have to give them something else in return, but we have to keep moving. We have to keep the boat moving. That's the behavioral psychology piece. That's the part that really is fascinating to me. But you do, I think, to go back to the diversity piece though, so we think about like Kentucky, it's a very white state. It's not nearly as diverse as other places I've worked. Like University of Chicago, like I didn't look like most of the people that worked there, right? So you immerse yourself, that becomes very normal, right? That was a very comfortable thing. But building it, like to Amy's question, like when you building it where it's not there, right? Nobody wants to be the token this or that, right? As a male OBGYN, in a very, very small way, I know what it's like to be like the token guy in the residency class, right? Clearly, it's just like a little bit of a window. It's not necessarily negative, but that does feel like a little bit like, am I just here because I'm a guy and you just needed to like mix it up a little bit? Or do you actually want me here because I'm good? How do you truly build diversity into an organization, into a residency program, into a department? Like how do you do that in a way that's sustainable?
I think first you have to truly believe that diversity does not sacrifice in quality. That is such a misconception. People think that when you are trying to change the structure of the way you do things so that you can have representation of not just race, there's diversity of thought, right? Where folks come from. There are many, many, many levels and ways that diversity looks. But when it usually starts to pertain to particularly changing the way a place looks with respect to racial and ethnic diversity, for example, or gender diversity, people start to act as though like, because you're changing it, you're somehow sacrificing quality. And I think if you have that mindset, you're actually not going to change things. You're going to tokenize folks. You said something, Mark, you said, do you actually want me here because you think I'm good, or am I meaning something? And I think that I'm not saying all folks, but there's some people that don't realize that opening up your lens to be able to say that I want to look for something that maybe may not be like the norm here, or that have this place not be homogenous, doesn't mean sacrificing rigor or standards. And those things are not mutually exclusive, excellence and diversity. And so I think if you truly believe that, you can actually like do the thing required to actually query, like, why does my place look the way that it does? Whatever you decide it needs, and then go out and get that thing, right? Because it's certainly not because there's a shortage of whatever the thing is that's going to make your space more representative of whatever population you serve.
No, that's great.
Well, can I just ask, this is like, I don't know, I'm just thinking of the future, like, how do you think AI or technology or, how is that going to address any gaps or help us analyze where the needs are? Or, just curious if there's like, how can it, there's some
Wasn't the first AI like super racist? Like one of the first ones?
Yes.
I was like, you have to look at what you're feeding the algorithm, right?
Right.
And make sure that it's not super racist or biased in
Yeah.
another way.
He's like,
It's
I'm just paying
fate.
attention. I'm just eating what you're feeding me, and it's pretty bad. It's pretty nasty. Like,
It is. I mean, I give the example of like, it's like systematic reviews or whatever. It's just based on the quality of the
garbage in,
data
garbage
inputs.
out.
At one point I was in Korea and I remember my cousin was like, do all Black people carry a gun? And I was like, no, but that's
Oh my
what was
God.
in the movies. I was like, I
Yikes.
started laughing. I was like, no, but like you think about the cultural hegemony that the US exerts. I mean, now it's K-pop probably, but it's just...
So is
You know,
everybody
that-
over there just dancing, Amy? Was that the,
Yeah, right. Exactly. It's having plastic surgery. I mean, I am
Yeah.
obsessed with that on Instagram, but I mean, but I just think that I worry about it. I mean, I think how AI is going to help is like, it's going to help us become more efficient, so we have more time to do the higher order stuff. Like I shouldn't be
I see what you're
worrying
saying.
about like
The higher
cover
order
letters.
thinking.
Yeah, like cover letters or thinking of titles, obsessing about these things.
like podcast questions?
Podcast questions,
I certainly don't use AI enough, and I need to like.
No, I think that I look at all of this with what I hope is a healthy dose of skepticism, right? Like everything is great until it's terrible. Like there's always like everything is just, if it's too good to be true, like, I just think, and maybe it's just being raised like Jewish and you just like, at every Sunday school class is like, let's talk about the Holocaust again. I'm like, I think I got it. Like, nope. Like it's just this like terrible things are coming, right? That's always just like, as a kid, that's like all we're taught like our entire lives. So I think I look at these big systematic things. I'm like, so how can this turn into something evil? How can this turn into something bad? And I think I'm just very suspicious. And with AI and these things, like you're giving people, again, I think I'll include myself. I think we're just all lazy animals, right? Like we just eventually want to go home and just like sit down on our couch at the end of the day. Like we want to do great things, but like I also want to just like relax. Like we're going to give maybe too many things to AI, some important things that, maybe we should be paying attention to, that we're going to maybe hand off some things that should still be done by people. And that's the worry I have, is how much of it just becomes like, we give it up and then we're not able to get it back.
I feel like I don't know enough about all the possibilities.
Well, let me tell you, watch out. It's going to be terrible.
I think it'll be fine. Don't let your catastrophism like kick in. God, Mark.
I am a little bit of a catastrophizer, though. I'm like, it's all gonna go. It's all gonna go down. Yeah. I don't know.
Because I know the people involved, at least you see like the people in charge of some of these companies, right? Why would I trust them? Their job is to make a bunch of money, which is not an evil pursuit, but like certainly Mark's well-being is not at the top of their list of things to care about, right? Like it's a big business. And if it's a business that all of a sudden just gets incorporated into every other business, like I just don't trust people to do what's in my best interest, whether they should or shouldn't. Like I think in general, like going back to the conversation you're here to talk about, the people in power designing these things, right, are doing it and they're going to want to hold on to power. And these people have a lot of money and a lot of power, and they're not going to design things that make things better for everyone just because they're nice people, right? I don't think that's where this leads without some government intervention. And right now we have to think about whether or not the government is going to intervene in a way that is going to make things better for everybody. That's right.
The government.
Right. I worry about people in power doing things just historically, right? Doing things that benefit those without power, right? That to me is what government's supposed to be for, is to protect us against our own humanity in doing things that are self-preservational. Government says, no, we got to have taxes. We got to have roads. So we all share. I know you don't want to give this money away, but like, we're just going to take it. And I worry that we're way behind.
Well, we'll see. I mean,
You speechless? You got nothing.
No, it's not, because it's just so dark, and it's fair.
And I don't mean it to be dark. I do it because I want people to think about.
No, it's
like,
legit.
what we can do about it, right?
Yeah.
Like I think you have to think about how this can go sideways to make sure it doesn't. You can't just pretend it's going to be a bunch of trillionaires going, here, please have nice things for free. Like, I'm not waiting for that to happen, right? Because it's just not going to happen. So we got to really think about how we protect the people who can't protect themselves, right? And that's where I think the benevolent, role of a leader, I would like to see more of that in our leadership than I'm seeing. Not at my institution, just in the world. I don't mean even political. I just want,
decision makers.
On that note, tell me what your vision is for a more equitable future.
Oh gosh, that is big. I would say in the short term, within the things that I can control, which is like, let's say start with our field, right? I would love to see our urogyn specialty, right, actually be leaders in thinking of ways to be inclusive in our research, in our leadership structures, and have patient outcomes that are like a template and a blueprint for other specialties.
I think that is definitely within the realm of possibility. And I will use this as a plug to say, get involved. I do believe in the inside game. So I think people have heard me say this over and over. The way to affect change in organizations is to have a sustained record of engagement and bringing your ideas, advocating, being involved, and rising to the top. At this point, I'm 50 years old. I've been with these organizations for a long time. And then people know what you're about, what you are interested in, the kind of concepts, and, just being present, what Mark is saying about just trying to make things better, trying to advocate for our patients, the best thing for our patients, the best thing for our field. I think that goes a long way. So, yes, of course, you can advocate on the outside, but I think it's really good to stay involved. And even when there's highs and lows in organizations, there always is. And I don't care if it's your hospital or your department or national organizations, there's people that you disagree with. Stay from the fray and keep your eye on the prize to maintain relations. And you don't want to go out the blaze of glory. We all have ups and downs in every organization.
But don't be afraid to cause some good trouble, though. I mean, don't be afraid to do the right thing when maybe even that's not what, I don't mean to break laws, but what I mean is, I'm not going to advocate for that on the show. Don't anyone call any lawyers. But no, I think sometimes just doing the right thing in spite of what everyone else is doing, like set your own bar for what is right, and you'll sleep a whole lot better. And not everybody's going to be happy about it, but most of us know what the right thing to do is. I think, Amy, I love your point. Get to the table. We need those voices at the table who have good sense, good ideas, and different perspective. I don't have the answers. I don't have all the answers, but you got to have folks who are open and willing to listen to help all of us get to that next best place.
Yeah, like including people when, as a program chair, it means having a diversity of views, having private practice people, having academicians, having gay people, having people of like different religions, having, diverse range of topics. Like there's lots of ways to demonstrate that, there's different things going on in the field, and honestly, people like that. It feels fresh, and like the things that really move the needle is people realize, even when they say it's always been done that way, but when you can't attract residents and fellows into your field or your fellowship or, recruit people, that's when it really becomes like a problem. So I've seen a lot of change just from what younger generations want, at these organizations. And I have seen the arc of that change quite a bit. I mean, Mark and I know AAGL really well. I've been at SGS, I've been at OGS, I've been at ACOG. It does change, based on the leadership there and the membership.
I love that. I'm like soaking this part in because this is folks giving early career folks advice. And it's so important to hear that. I think some people don't think about the value of, like you said, sustained engagement in your national organization. So I appreciate you saying that because I have to hold on to that, right? And think about that. Because to your point, Mark, it's extra time, extra investment, but to your point, it's worth it.
And when you do have a seat at that table, always look around to see who you can bring up. Somebody brought me up I didn't do it on my own. I got invitations to certain things. You have to make the folks that come behind you, make it so the folks that come behind you bring something that you didn't bring, have some ideas that you didn't have. It cannot look the same after you, and providing those opportunities. That's the fun part for me in any of these things, is all the folks that have helped me out, all the people that have like just dragged me along, to get any chance to help them out is very rewarding. But just to make sure we don't just keep making it look the same, right? We have to let it evolve and see that your way is not the best way. And then I get accused of being too self-deprecating at times, but I try to make sure you maintain the humility in that. Like, okay, I matter, but other folks have really interesting ideas that I just would never think of, and that matters just as much.
Absolutely. I second that. It's so important. So anyway, keep up your efforts, keep engaged. You're doing it obviously on your local level, but for everybody out there, I have seen so much change in just my time at this level. So it can, if you are, I've seen also colleagues of mine get disgusted with X, Y, and Z at the organization, and they just quit their committee lead position. And it's like, well, now somebody else has to take that job who doesn't, they're just going to fill you with somebody else, truly. Is another spot to fill. So, just channel your energy into trying to do some productive things and tangible goals and vision. I think people appreciate that. Like you were saying, the program that you put together, there were tangible plans and strategy and a rubric, to address things. I think people really appreciate that. And that's part of your educator portfolio when you go up for academic appointments and, things like that. So, and then, what we're trying to do also in our department is just put a name to all the work that we do that is unpaid labor, like the mentorship of people, and we're going to call it a mentorship committee. This is from Star Hampton. We're going to meet with her and try and operationalize it. But what she did at Brown, like talk about this and put a name to it and recognize the efforts, because really it's so important. Your work, the work that educators are doing, it's undervalued, underappreciated. If we can just make it a line in our CVs and put a name to it, I think pitching your ideas is super important too. I have seen so many people create jobs for themselves. But vice chair of faculty development, like when I was at Georgetown, they got one, So, just if there's good ideas, try and pitch them. And I think people really appreciate that. And when you come from a place of trying to help everybody else, I think people appreciate that. It's something radical about being you, authentic self. I think that's okay too. You know what I mean? So I think people forget about that. Yeah. Just like having good work-life balance, trying to put forward good ideas, trying to be, have a humble attitude, giving people credit. I think people do see that and appreciate that. And it's much better now than when Mark and I came up. Don't you think, Mark?
I can't even imagine.
I'm not that old. What do you mean how? You can't imagine way back when.
People talk about that. No. It was not as collaborative.
Amy's older than me, by the way.
I am older than Mark.
I can't believe Amy is the age that she shared. This is like ridiculous.
I think I'm 5 years older than Mark.
4, but I look more than 5 years older than you, so that's really where it counts, I think. So
yeah, but anyway.
Well, that was super fun. That was really interesting.
That was a lot of fun.
And there's not really anything more important than the work you're doing. We're so grateful that you came and shared the work you're doing, and just again that little piece of just like. How can I make a difference? Like just so many examples of what you've done, like what one person can do. And that's inspirational for those of us to go back in our work and try to think of ways we can try to make an impact where we are. And I think that's really powerful.
You guys are awesome. Thank you so much for having me. And it's not just one person. It's like an army, right? Like there are folks who like Amy, people who see what you're doing and say, we want to support that and we want to join you. And so I appreciate both of you. And, Amy's a sponsor, and I appreciate you thinking about my voice and giving me space to be able to talk about what we're doing and what we care about.
Of course. Yeah, we love what you do. We're just happy to be part of the journey. So thanks for coming on.
Thanks, guys. It was lovely to meet you, Mark.
You too. That was fun. And I hope to hang out with you at some point in the future in real life.
I will find you. We'll find each other somewhere. All right.
Well, have a good night. Thanks again.
Good night.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Overjinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham. Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.